Hiya folks, history taking station in MRCPCH clinical exam is one of the stations where you need to score the maximum points along with development station. History taking and development, these two stations RCPCH gives a lot of priority, and that's why you would notice that it's the most lengthiest among all the stations. There's around 22 minutes, so you need to make sure you score the maximum points in these two stations. History taking, for many of us, it might appear to be pretty straightforward because we all would have taken a lot of countless amounts of history in our day-to-day life. But in this station, it's not as easy many times because you have 4 minutes to prepare for the scenario that you get. And you have 22 minutes for this entire station. You need to score a maximum, for which you need a proper structure, and you need to jot down and ask all the questions quite shrewdly, and you should cover everything. And your history must be very extensive, and to a point that you should scrutinize from the history. You should come to a diagnosis. So it should be so extensive that you should be able to reason it out when you pick a diagnosis eventually after the history taking, that after you summarize and you come to a conclusion that this is the diagnosis. From the history, you should be able to give a primary diagnosis and a differential. So, and when you give a primary diagnosis, in the end, when you summarize, you have to tell your examiner, you have to reason it out as to why you chose that particular diagnosis. So today, I thought of discussing about type 1 diabetes history taking scenario. This is quite common in the UK. So this has come multiple times in the exams as well. So the scenario is like a 15-year-old child who had basically good control. HbA1c levels were good, but now has come with bad control. The levels have increased. So the child has lost control. So what are the new changes that has happened? And so you should take a history as to come to know why the child is not having a good control at the moment. We all are really good doctors, and we might be quite well versed with the etiologies and reasons as to why an adolescent could actually lose good control of his or her blood sugar. But the hack or trick is to extract this piece of information from the child who's sitting in front of you for your exam. For this, you need a structure. If you don't have a structure, you may not be able to ask all the questions, and all these questions may not come to your head in that 22 minutes, because we might know the entire reason and all the information might be there in our head, but it has to all come out, and we have to ask and make sure and find the exact cause. That's why the station is where it gets really tricky. It's like a mental block, because we are in a lot of pressure and we are a lot of stressed, and we only have this limited time frame, and we may not be able to perform really well if we have that mental block. So we have to let it all out. So for which if we go through a structure, we can really crack this station and make sure we have extensively asked a lot of history and find the exact reason why the adolescent has lost his good control. So first, I would recommend asking the initial diagnosis as to at what particular age the child got diagnosed. Many times in the UK, there are children who get diagnosed at the age starting from 3 years of age, 4 years of age, like really insulitis, where they have really autoimmune antibodies that really knock their pancreas off, and they are diabetic from the age of 3 years, and they have good family history as well. So they could be starting at the age of 3 years or 4 years, but many times it could be in the adolescent age group, like 10, 11, 12, in that age group. And they don't come to know, many times parents don't know that the child is diabetic, and their first presentation will be in DKA. So you ask the age, and then were you in DKA when you got first diagnosed, and were you admitted in PICU? Was there a need for you to go to the PICU? Or you can ask how long your length of hospital stay, And then post recovery from ICU or post DKA, where did the diabetic nurse and the lead pediatric endocrinologist give you were there sessions where you were properly educated regarding the disease and the medications and the follow up. So those sessions are very well are quite commonly done in children's ward. So you need to ask if they were given proper education. Then you can move on to the past medical history, like now how many times, number of hospitalization, how many times have you been admitted in the hospital. So you come to know how bad, whether the control was good, how bad and how good it was, and how bad it has become. And frequency of monitoring. So next is like frequency of monitoring. So you can ask, if do you keep a diary of blood sugar or ketones. How often do you check your blood sugar? Do you have a continuous glucose monitoring machine like Libra Freestyle, or do you have to prick yourself? So how often do you do that? And then whether there has been a recent change, how many times have there been a change in your insulin regimen? Then how when was your last OP visit? Then you could ask, do you think do you think there is your growth is being affected? Then you could ask, have you had any hypoglycemic episodes, especially when you were like driving or cycling or bathing. And so that's the past medical history. Then you can move on to social history. This is where many times you could find the exact reason as to why the child is become non-compliant, or has become got worse from good control to bad control. So rest of the things we might be well versed, but the social history aspect could be a deadlock. Like this could be the area where you need to explore extensively. So you start with asking like, how is the disease affecting you, your school, how is the disease affecting your friends group, is it affecting your school, and are you in touch with any support groups or support camps? Is there any bullying at school? How are things in school? How's things in the family? Is there any factors that is stressing you out? Are you worried about your body image? And is your family supporting you in your diet? Has there been a change in the family's diet? Do you have siblings? Are the siblings, do they understand your disease, and are they helping you out with your disease and helping you out with the diet? And have you ever taken do you have any risks taking behaviors, like have you ever self-harmed? Is there any psychological aspects, stresses that are bothering you? Then has there been a dietitian ever involved in your care? Have you spoken to is there any social services involved in your care? Is there any, do you carb count? How do you use an app for carb counting? Is there any diet plan prescribed by a dietitian? And then you should never forget about the specialist nurse. Are you in contact with your diabetic specialist nurse? Do you have any clinic appointments coming up? When was your last appointment? Do the specialist diabetic nurse do home visits? Do you have your specialist diabetic nurse's phone number? These questions you should definitely ask. Many times we the candidates do often miss these questions, and this could be the aspects. This could be the reasons which this could be the piece of information which you actually want, and you'll come to know that the child is not compliant. So many times in the cases of adolescents, it could be a social history, the factors in the social history aspect, where you can get the appropriate diagnosis. And then you can also ask, like, are you what, like I had earlier mentioned about body image. So you could say, do you have any Any, you could ask for history suggestive any lipohypertrophy or lipoatrophy. Are you worried? So there is this myth among children that insulin can make them gain weight. That is for people who have, like, a lot of insulin in their body. If you take again insulin, you can basically, insulin is an anabolic hormone, so you can gain weight. But when your body is deplete, so you make the child understand. I mean, children do have this myth that insulin could make them fat. So you tell them that insulin is an anabolic hormone, and basically it increases your metabolism, and it can lead to gain in weight only for those people who have a lot of reserve of insulin in their body. Like, if you have a lot of intrinsic insulin reserve in your body, then if you take a lot of insulin, like extrinsic insulin, you will gain weight. But these children are many times intrinsically depleted, so they don't have any insulin reserves, and that so you definitely have to take insulin. You have to extrinsically supplement insulin into your body from outside, because your body is not producing insulin. So you are not going to gain weight by taking this medication. You have to diet control yourself, and work out, and have a proper exercise regimen in your lifestyle, so that you don't gain weight. And if you don't do that, if you have a sedentary lifestyle, you will gain weight. But this medication as such, insulin as such, will not gonna is not gonna cause gain in weight. Then you move to the current treatment history, where you can say what type of insulin are you on, when was the last time it got modified, a change in any dosage, is there any new diet which you're following, have you I've like, you could ask, have you when was the last time you visited a dietitian, or are you following a diet plan, are you carb counting, then uh, yeah, do you follow carb counting before you administer your insulin? Then many times you need to ask, do you change your site of injection? Like, it has to be changed every 3 weeks. So how often do you change the site of injecting? Then storage of insulin. So many times the children are on these insulin pens, so it has to be stored at 2 degrees to 12 degrees Celsius. So where do you keep your insulin pen? Do you keep it in the fridge, or you keep it outside? So you should make sure they are kept inside the fridge at this particular temperature, and you should also let them know that you should never keep the insulin pen inside the freezer. You could never use insulin that has been frozen. And then how often do you check the expiry date of the insulin pen? Then and if at all insulin has been kept in a temperature above 37 degrees Celsius, it has to be discarded. Now, if they're on insulin pumps, so if the child is diagnosed to have type 1 diabetes at the adolescent age, like 11, 12, at that age group, they in the UK, they're not given insulin pumps, whereas they're given insulin pens. They're properly educated, and their competencies are like Gillick competencies, and their understanding of the disease process is made is gauged, and they are given these pens, and they are told how often to give the medication and how much to carb count. So they're given proper education. So the adolescents are usually on insulin pens, whereas the younger children, like 3, 4, 5 years of age, these children, you can't. It's very hard to educate them, because they are just small children, so they can't diet restrict, or they can't understand the concept of pens and getting poked. So it's the smaller children who are given insulin pumps in the UK, and the adolescents are given insulin pens. So a child who has been on insulin pump, starting who got diagnosed very early, then they when they are transitioned onto adult care, they go on with insulin pumps. They don't go to insulin pens. So if the children are on insulin pumps, then you ask them, how often do you change your insulin set and your pump, it has to be changed every 2 to 3 days. So do you do that very often? How often do you do that? Have you changed it? Then So sometimes there's cosmetic issues. There are like the three different types of pumps. Usually one is Omnipod, then there's something called Medtronic, and there's something called T Slim X2. The Medtronic and T Slim X2, the tubings can't be hidden. So many times they don't want to, these tubings are like hanging on them, and they are like embarrassed to be around with their friends or go to like a summer or swimming pool party, or extracurricular activities, because they are always attached and they have the stigma, and they're embarrassed to show these tubings in front of their friends. So and then I will give you a little insight on insulin pumps. The insulin pump, the basal and the bolus there's only one insulin inside the pump, that is regular insulin. So it has a basal regimen and a bolus regimen. So both of it is regular insulin that is given. So there you can't put two insulins in the pumps. The things are not so advanced. Most of the pumps at the moment have only regular insulin in them, and that is usually Actrapid. So Actrapid, it peaks at 1 to 2 hours, and then the entire action lasts for 3 to 5 hours. So as you know, these insulin pumps have cannulas. So you should ask if the cannula is not, has it gone, is it functioning properly. So, and if the child might not know many times. So the specialist nurses train these children to see if the cannula is properly inserted. If it's not properly inserted, what happens is they slowly slip into decay. And because the cannula, if it's not properly inserted, it won't the insulin won't be administered into the body, and the insulin action is only for 3 to 5 hours, if at all. The insulin that has been already gone into the body, it will stay in the system for only 3 to 5 hours. And if the pump's cannula is not properly gone in, is not properly inserted into the subcutaneous tissue, the child will think that the pump is working, but basically it is not delivering. So are you aware of this, that your pump is properly working? Do you know how to look at your the cannula of the pump? And so what happens is what happens many times is that the insulin pump doesn't have long acting insulin inside it. It only has normal Actrapid. So where if they're exercising, the insulin acts better and quick, so the blood sugar can easily plummet after a workout or after a spontaneous activity. So they can have many times go into hypoglycemic episodes. So you should ask, do you reduce your basal rate well in advance before any physical activity or exercise? How often do you do that? Are you aware of this? So you need to ask this history. Do you often reduce your basal rate well in advance before any physical activity? Then moving on, there are another set of questions in order to know the reason for why they've lost good control and become bad control. You could ask for history suggestive of any hypothyroidism, because there could be multiple polyendocrine. Some children could have polyendocrine disease, so not just the type 1 diabetes, they might have hypothyroid concomitantly as well. So you can ask for history of any hypothyroidism, like history suggestive of hypothyroidism. And many times children have celiac disease associated with type 1 diabetes, so you should rule out history of celiac disease. Many children have Addison's disease, so you should take histories of suggestive of Addison's disease. Or is there any recent infections, like an infected skin infection or ear infection, underlying infections that is messing their insulin, messing with their insulin. Then another thing I actually missed in the social history. You could ask if there are any things which is stressing them out, like parental conflict. You would be asked about bullying in school. Then you could ask, ignorance, like how good is the child's understanding, like poor understanding of the disease. So how good do you understand this disease process? have you got into any bad habits, like, have you started vaping, or due to peer pressure, have they gone and started alcohol drinking, like binge alcohol drinking, night outs? So this can easily screw up their metabolism and their diabetic control. So these histories you definitely need to ask. So the I just wanted to let you guys know these are some of the histories which many times we often miss in our, because we only have limited time frame, and due to we are already in a lot of tension, and we want to score the maximum points. Just keep in mind, just jot down these things which I've mentioned, and then if at all you get this scenario, if you go through almost all these points that I've covered, I think you can come to the exact cause for the poor compliance. As I said, I hope this has been effective for you guys who are preparing for the exam. Best of luck once again. Until next time, take care. Bye for now.